Okay, so let's set the scene. A patient comes into your clinic or the ER, they're in their first trimester, and they're bleeding. Their heart is racing, and let's be honest, so is yours. This is one of the most common and most high-stakes situations you're going to face in OB/GYN. How you think, how you act, it really can make all the difference. So in this explainer, we're going to build a mental framework, a step-by-step guide to help you handle this challenge with real confidence.
Here's our game plan. First, we're going to cast a really wide net with our differential diagnosis. Then, we'll zoom right in on the one thing you absolutely cannot miss: ectopic pregnancy. After that, we'll tackle the most common cause, miscarriage, and then look at some of the less scary reasons for bleeding. Crucially, we'll also talk about the emotional side of this for the patient. And finally, we'll wrap it all up with a clear, step-by-step clinical approach.
All right, first things first. Before we can even think about narrowing things down, we have to know what all the possibilities are. Building a really solid differential diagnosis, well, that's the bedrock of good, safe clinical practice. So let's really put ourselves in that room. The patient is there, they're scared. What's going through your head? What's on your list of possibilities? Because it's a huge range, right? From a life-threatening emergency all the way down to something totally harmless. A really fantastic way to organize your thoughts here is to think about anatomy. Where could the blood possibly be coming from? Is it uterine or tubal? I mean, that's where the big, scary stuff lives. Ectopic pregnancy, miscarriage. Or is it coming from the cervix or vagina? That makes us think about things like an infection or trauma. And don't forget to think outside the box a little. Could it be something nearby, like the urinary tract or even hemorrhoids? Okay, so now let's focus on the absolute most critical diagnosis on that list: ectopic pregnancy. This is where a fertilized egg implants outside the uterus, and it is a true blue medical emergency that you cannot afford to miss, period. And here's why it's so serious. Ectopic pregnancies themselves are relatively rare, maybe 1 or 2% of all pregnancies. But look at this number. They are responsible for a huge, disproportionate number of maternal deaths. This stat right here, this is why it has to be at the very top of your list every single time. The stakes are just incredibly high. Now, sure, there are some classic risk factors we all learn about, right? A history of PID, previous tubal surgery, all that stuff. But here is the absolute key takeaway. About half, 50%, of all ectopic pregnancies happen in women with 0 known risk factors. What does that mean for you? It means you have to have a high index of suspicion for every single patient who walks in with first trimester pain or bleeding. So how do we actually figure this out? Well, our diagnosis basically rests on 2 powerful pillars, a sort of diagnostic 1-2 punch. We're looking at the blood levels of the pregnancy hormone, beta-HCG, and we're using a transvaginal ultrasound to get a direct look at what's going on. Neither one is enough on its own. You have to use them together. Let's start with the HCG. In a normal, healthy pregnancy that's growing inside the uterus, that HCG level should be shooting up. We expect it to rise by at least 49% over a 48-hour period. If you see it rising much slower than that, or if it's flat or, God forbid, dropping, that is a massive red flag that something is wrong. It's either a miscarriage or an ectopic. Okay, the discriminatory zone. This is a super important concept that links our 2 diagnostic tools. Think of it like a threshold. It's the HCG level where we say, okay, by now, we should definitely be able to see a pregnancy inside the uterus on an ultrasound. So, if the HCG level is above this zone, and you look with the ultrasound and the uterus is empty, well, the alarm bells in your head should be screaming ectopic. So you've made the diagnosis. Now what? Well, you've got 2 main paths, and the choice depends entirely on the patient in front of you. If they're stable, the ectopic hasn't ruptured, and their HCG levels are on the lower side, you can often use medical management with a drug called methotrexate. But if the patient is unstable, if you think they might be bleeding internally, if there are any signs of rupture, that's an emergency and they're going straight to surgery. Okay, so we've covered the most dangerous cause. Now let's shift gears to the most common one. Miscarriage, or what we call spontaneous abortion, is unfortunately a very frequent event, and it's the reason for the vast majority of first trimester bleeding cases. So the textbook definition is pretty simple. It's the spontaneous loss of a pregnancy before it's considered viable, and that cutoff is usually around 24 weeks. A quick but really important clinical pearl here. When you're talking to patients, please use the word miscarriage. The word abortion can be really confusing and upsetting, as it often implies that it was an elective choice. Now, miscarriage isn't just one single thing. We classify them into different types based on the clinical picture. And we do this because it tells us what to do next. The key questions are,
Is the cervix open or closed? And is there still pregnancy tissue inside the uterus? For instance, in a threatened miscarriage, there's bleeding, but the cervix is closed and the ultrasound shows the pregnancy is still viable. On the other hand, in an inevitable miscarriage, the cervix is open, the loss is, well, inevitable. These details are what guide our management. Once again, ultrasound is our go-to tool. The sonographer has a very clear process. First, find the gestational sac. Then, look inside for the fetal pole and measure it from head to bottom. That's the crown rump length, or CRL. And then the critical moment, looking for a heartbeat. Here's the rule of thumb. Once that CRL measures 7 millimeters or more, you absolutely expect to see cardiac activity. If you don't, that confirms the pregnancy is non-viable.
All right, we have covered the major issues inside the uterus and tubes. But what happens when the bleeding isn't coming from in there at all? Sometimes the source is actually the cervix itself, and this can really confuse the picture and mimic some of those more serious problems. And here is a perfect example of what that might look like. This is a picture from a speculum exam showing a cervical ectropion. See that reddish, kind of raw-looking ring of tissue right around the opening of the cervix? This is a super common and totally benign finding in pregnancy. So what is this thing? It might look a little scary, but it's not a disease. A cervical ectropion is just a normal change that happens because of the high estrogen levels in pregnancy. Basically, the delicate glandular tissue from inside the cervical canal turns outwards. This tissue is way more fragile and has more blood vessels than the outer cervix, so it can bleed really easily with any kind of contact, like sex, which can be super alarming for the patient. So we have gone deep into the medicine, the diagnostics, the algorithms, but our job as clinicians does not end there. We have to look beyond the physical diagnosis and address the profound emotional impact this has on our patients and their partners. This quote really says it all. The psychological fallout from early pregnancy loss is not just sadness. It's real, it's measurable, and it's significant. We're talking about high rates of depression, anxiety, even PTSD-like symptoms. And it is so important to remember this doesn't just affect the woman. Partners often experience significant grief and anxiety as well. Okay, let's bring all these pieces together. We've looked at all the possibilities, the emergencies, the common causes, and the human side. Now, let's synthesize this into a clear, actionable plan that you can use in the real world. This flowchart right here, this is the mental model we've been building this whole time. This is your roadmap. It all starts with the single most important question: is the patient stable? If the answer is no, everything else stops, and you resuscitate. If she is stable, then you follow the path down. You check for signs of infection, you differentiate between an intrauterine and an ectopic pregnancy. This kind of structured thinking is what keeps patients safe and keeps you from missing anything critical. So what are the big takeaways? If you remember nothing else, remember this. Number 1, always prioritize ruling out an ectopic pregnancy. Number 2, HCG trends and ultrasound findings are a team. You have to interpret them together. Number 3, don't be afraid to look. Always do a speculum exam to see the cervix. 4, classify the type of miscarriage because that's what tells you what to do. And finally, never ever forget the person. Acknowledge and address the huge psychological toll this takes.
And this really brings us to our final thought. As a medical community, we're getting better and better at the science. Our diagnostics are sharper, our treatments are more refined. But the question we have to keep asking ourselves is this: how can we get better at the art of medicine? How can we better support our patients through the terrifying uncertainty and the deep emotional pain of these complications? That's a challenge for all of us.